Asking everyone to mute themselves and turn off their cameras, that would be great. So you have joined us for Healthy Aging and Identifying Frailty. My name is Phoebe James, and I'm a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the land we are all meeting on today and pay my respect to elders past, present, and emerging. If you are just joining, please, just out of courtesy, turn off your camera and please be on mute, just to minimize disruptions. This session is being recorded, and the recording and the PDF slides will become available on our PHN website in the Education Library in the next few days. We're having a Q&A session at the end of the presentation, so please feel free to put your questions in the chat function. I will also be putting a link to an evaluation in the chat function throughout the presentation, and I will be eternally grateful if you could complete it. Tonight, we are lucky to have chairing this event, Dr. James Wolstenholme, who works at Mingara Medical Centre and supports a large cohort of older patients residing at home and in residential aged care facilities. I will now hand over to James.
Okay, now.
Thank you, Phoebe. Good evening, everyone, and welcome to this evening's meeting. Our subject this evening is healthy aging and identifying frailty, and I'm sure everyone in our audience would agree this is an extremely important subject in the context of an aging population, and particularly given the population demographics in our area. In fact, I did some digging, and in my area on the Central Coast, the population census in 2021 recorded that the 70 to 74 year age bracket was the one that had grown the most since 2016, an increase of about 6%. So clearly the aging population is expanding, and this, of course, brings with it significant healthcare challenges. And therefore, we're very fortunate this evening to have two speakers with a wealth of experience in this area. So later on this evening, we have Dr. Peter Ward, who is a semi-retired geriatrician in Georgetown, Newcastle, who is also co-chair. In fact, he was the inaugural co-chair of the Hunter Aging Alliance. Peter has a long-standing but increasing interest in healthy aging and the prevention of frailty and sarcopenia, and we will be hearing from him a little later. But first, I would like to introduce Dr. Chris Bollen, who is a GP currently practicing in South Australia. And in fact, he has been practicing today in South Australia. And he is the Deputy Chair of the AMA Council of General Practice. For the past 6 years, Chris has been educating health professionals on better care of the elderly, with particular focus on cognitive and physical frailty. And I would now like to hand over to Chris for his presentation. Thank you.
Thanks very much, James, and thank you all for having me. I'm just going to get the share screen up. And of course, Phoebe, that slide's not coming up right now, so just bear with me. Right, there we go. Okay, come on.
There we go, I can see it.
You can see the right slides?
We can see the meeting at the moment and then the slides, yes.
Okay, I'll just get that up. Thanks. Sorry everyone about that. It's a little technical dilemma. So, okay, so what, as an active GP, one of the big sort of concepts we're going to talk about tonight is identifying frailty, and Peter's going to talk a little bit about healthy aging, sarcopenia as well. So before we progress, what I'd like you to do, I want you to think about this video I'm going to show you. And what's going to happen is I want you to think about that the Hunter New England Central Coast Primary Health Network and the LHDs are going to put this particular advertisement on TV screens across the region. I want you to think about, are you ready for this? So very short and sharp, but very poignant. And if this was an advertising campaign going across the region, how would our primary care practices respond to older people coming in saying, I saw this ad, doc, apparently you can do something. And so I guess tonight is about introducing you to the concepts of frailty as a long-term condition. Frailty is something that can, in many ways, be reversed, and it's something that is straightforward to do. But the unfortunate thing is it doesn't come in a pill or a bottle, the solutions. So I'm going to just talk a little bit briefly. This is the take-home message first up, just in case you fall asleep during my presentation or we run out of time. But we're going to talk a bit about screening for frailty. And it's a long-term condition. It's been accepted now as a long-term condition. And so screening is something we can do in our practices. And there are about 250 screens for frailty around. Now, as a GP, I like to keep life simple. We don't have a lot of time. So, John Moore. Now, there's someone's microphone is on there. I'm just getting a lot of feedback. So John Morley is a geriatrician from St. Louis, and he came up with the Frail scale. It's Frail. I love this one because it's very conversational. F, are you feeling fatigued? And if the person says yes, there's a point. Resistance. So resistance, difficulty walking a flight of stairs. That's getting your body weight up 10 steps. Do you have difficulty walking a flight of stairs? Yes or no? Ambulation. Do you have difficulty walking around the block? 300 meters. Yes or no? Illnesses. Do you have 5 or more long-term conditions? Yes or no? Loss of weight of 5% or more over the last 12 months? Yes or no? So if an older person scores 1 or 2, they are considered pre-frail. More than 3 or more indicates they're frail, and they would actually benefit with improved physical activity, polypharmacy review. Let's address their fatigue. Let's look at protein and calorie supplementation. As we'll hear from Dr. Water later, malnutrition and low protein is prevalent in this community. And I saw one of my patients this morning that has been losing muscle hand over fist after a fall. She's just not doing anything, not eating enough. And vitamin D is helpful for this group. So that's the Frail scale. So we'll come back to that a little bit later. But I want you to think about, really, why do we need to be here? And James talked a little earlier. He'd looked up some of the data of the region, in his region, and I've looked it up as well. So the proportion of people in Australia aged over 65 in 2016 was only 12%. It's gone up 5%. The latest census from last year is 17%. Now, I couldn't access the Hunter regions 2021 or the New England 2021, but clearly in 2016, Hunter and New England and Central Coast all had higher proportions of people over 65 than the rest of Australia. The Central Coast was the standout. As James said, 25% of people are aged over 65 in the Central Coast. That's astounding. So that's really interesting. What does it mean, though, when this group of people who are aging all have multimorbidity? As we all recognise, people over 65, 50% of them have at least 2 chronic conditions. So this is a group that's getting older. It's a group with lots of conditions, and they have an impact on our practice level. Now, the impact on our practice level is, no doubt many of you are aware, but I'll just step it out for some of you that haven't actually looked at your own practice data, your demographics. So there are many practices that actually have a lot more than 25% of their population is over 65. Many are at 20%. Now, what this means is that this group come to the doctor more frequently. So on average, if you look at the 85-year-old group, so the data from Medicare says this group comes between 17 and 19 times on average per year. The average Australian comes to the GP on average 6 times per year. So that's across all age groups. So if you think about this older age group coming along a lot more frequently, You've got a practice population with a lot of older people in it. We know that, and having spent this afternoon in my practice with a lot of older people, they take longer, they have a lot more long consults, they are slower to get dressed and undressed, up and down off the couch. Everything slows down in your practice. So the impact at practice level is, and this is what workforce planners have not been doing, having a look at this impact in primary care. If we think we're busy already, not enough GPs, not enough nurses, population growing, population of the over 65 to 105s growing at a huge rate, their needs are really a big issue. So one of the big other areas that impacts the practice level is the lack of training in geriatric medicine for GPs as well as primary care nurses. So this has an impact on our ability to respond, and I use the term, while this silver tsunami is occurring in our local areas, there is a grey glacier in response at a government, at a national and a local level in how we actually help improve the health services to respond. The other reason we need to be here, this same group of people that we're talking about, 50% of people over 75 are on 8 or more medications. Now, they may be over-the-counters as well as your prescribed medications. So there's plenty of medications in this group. 40% of this group will have an eGFR of less than 60 mils a minute. So by definition, they will have chronic kidney disease. Chronic kidney disease, this has an impact on the way medication is actually distributed across people's bodies. Side effects are increased, but also medications impact chronic kidney disease. Multiple prescribers are involved that have single disease, single organ focus from our specialist colleagues, and rarely is deprescribing occurring. So we need to think really, who is going to be doing deprescribing for this group? And it's us, GPs, in our practices now. I see this as needing to be my favourite hobby now, the option of deprescribing when I look at how older people are coming into our practices, because no one else is going to be doing it. Geriatricians do, but often that's at the very pointy end in the acute care sector rather than in community settings. The other reason that we need to be here tonight is we've had a Royal Commission into aged care, the quality and safety of the care. And general practice and out of hospital care and home care was not excluded from this review. And if you go and look at the recommendations, it really says, right, a lot more care is required in all facets of care of older people. So when I look at this in our practices, we really need to think about how are we delivering the care? Have we got the right training for our nurses and our doctors? Have we got the right templates for our health assessments that actually make a difference? Now, I say that because I've reviewed around Australia lots of software, lots of templates for health assessments and care plans for older people. And by and large, if it's what the software companies give us to use, they are inadequate for what is required. Because Mrs. Smith, who is our stereotypical older person on the screen there, she will have visual issues, hearing issues, she'll have mobility issues, likely to have cognitive issues. She's got osteoporosis with that lovely kyphosis, plus a myriad of health issues. And she's got this fragmented care with all these providers involved, often not talking to each other. The ability for us to communicate for this vulnerable age group is limited. Unless we actually look very carefully at the information that we put into all of our health summaries, our templates for health assessments and care plans, and we're sharing them across the community of providers. So can we do any of this differently? So this is a really important slide for tonight, and we've got a lot of very experienced clinicians on board tonight. So, I want to accept that, this may be something you've already thought about. But why I present this is because sometimes when we are very busy, when everything gets stressed in our practices, we often are just doing the reactive care. And the care of older people needs to be considered as a proactive opportunity to do things differently. So I want you to think about this. And let's think about ourselves, our older selves, or maybe it's our parents, our grandparents, an older relative that we were looking after. So let's look at this. They might have said 5 years ago, I'm not as steady on my feet as I used to be. Did anything actually happen? They remain independent, but they were just saying they were just not as steady. Then another few years roll by. 2 years ago, there's a comment, Dad's slowing down. Did anything happen? Did anything change? And then a minor illness occurs. And this minor illness, and many of you will be familiar with this, that might have been upper respiratory tract infection. It might have been a UTI. It might have been a change in medication. It may have been, I've seen this plenty of times in the last 2 years, a COVID vaccination, where something has actually impacted this older person who's been on the trajectory of decline. Their minor illness has suddenly caused them to collapse. They've actually dropped into a level of dependency because they've become very unwell. Let's look, a respiratory infection, a UTI, temperature, palpitations, maybe a run of AF, drop their blood pressure, fall over, fracture something, end up in hospital. And their level of dependency has increased hugely. So all the little dominoes have fallen over, and that older person who's been on the trajectory of decline has suddenly become very dependent. Now, they may be fortunate and they get treated, and in hospital, bit by bit, they get back to getting home, but they're not as independent as they were. They need some extra supports. They are then now a fall waiting to happen, because as we all know, we've been in hospital for a week, you lose 10% of your muscle strength in that week. And often not much is being done to improve that muscle strength either in hospital or on the person's discharge home. So they remain a fall waiting to happen. So I want you to think about that, because look at all of our older people that we see. This is the trajectory that they will be going on. And if a person has this sudden drop in independence to be dependent, it's highly likely that this person is frail and it's not a healthy aging situation. So we need to think about this and why we want to be proactive. Could we have done something differently back 2 years ago, 5 years ago? And tonight, I want you to think this through, because it can be done differently. The other issue I want to raise with you tonight is the other issues which do not support older people achieving their good health. And the ones in red, okay, the health professional's attitude towards aging. What do you expect, Joe? You're 85, you're getting old, not much can be done. Now, this is something that many older people who are my patients who come to me as new patients have said, this is what my health professional has told me, that not much can be done. And we've got to actually say that is creating a major issue, because what the older person does, they've come to a health professional, you're in a position of power, and you said not much can be done. You're pretty well throwing them on the scrap heap. They then take that attitude away. Their self-belief in anything they can do will make any difference is out the window. So we all have to lift our game in the way we communicate. That language is unfortunately creating an epidemic of negativity, and it will actually create a problem where an older person will just think, I'm a burden, not much can be done. And so they'll sit on their couch, getting lonely and losing their interest in life. So we have a really big responsibility as health professionals to change our communication approach. Clearly, community also, there's a social stigma of aging that needs to change. There are a whole lot of other issues about communication. And I actually wrote to a surgeon this last week about his lack of communication with one of my 80-year-old multi-morbid people with cognitive impairment. They haven't been diagnosed dementia yet. She's in that assessment phase. He had not sent any letters back, despite my referrals, to let me know what was happening. The older person comes along, tells me, I've got no idea what's really happening, doctor. I saw the doctor, but I didn't really understand what was happening. So as GPs, and many of you will be in the same boat, we're in a very difficult position when our peers out there as surgical colleagues or physicians or hospitals do not communicate. How are we supposed to lift the baton and be able to take on the care that hospitals and others are expecting? So in the end, this is what older people are going to be saying. They don't want to go to residential aged care. We look at the data in the last 18 months, the increase in requests for home care services has risen 46%. COVID and residential aged care has frightened people, that the stories that the media have been putting out there about what happens in aged care has been terrible. And I work with a lot of aged care facilities. They've been doing a great job. It's been hard, but older people and their families are really disinterested in going to residential aged care. So we need to actually think about what can we do to help them stay well at home. And this picture tells you something. It's not a fake picture. It is possible to build muscle at any age. And it's really important we have this very positive message. It's never too late to build muscle. And I've got so many sort of situations in my own practice, older people, where they have been dumbstruck with how they have improved with simple exercises at home. I'm going to talk a little bit about that in a moment. But what matters to older people? It's their functional ability. They're not really interested in their diabetes, their blood pressure, their airways disease. They're interested in what they're able to do, their functional ability. And this is about having the capability to actually get stuff done, the things they love doing in their lives. So, and the things that they value. But often this is not even discussed in our care plans, in our health assessments, about what really matters to them. We've got to actually help them be more engaged with their own healthcare. And that means that we, as health professionals, need to be more engaged with their goals and ask them what matters to them. We're going to talk about the Frailty syndrome tonight. Again, Dr. Ward will explain more, but I want you to think about this concept that Linda Freed, who's a geriatrician from Canada, described, that frailty, I know it's a terrible term, and I don't say to my patients, oh, you've got frailty, because it just doesn't cut the mustard with a discussion. I talk about healthy aging, and I talk about loss of muscle mass having an impact on what's happening to them. But frailty is essentially a multi-system impairment. That's right. It's not one thing. It's not two things. It's multiple systems happening or being impaired at once. And it's associated with increased vulnerability to stressors. So as I showed that picture before about the decline and then the sudden drop in levels of independence as a result of a minor insult, such as a vaccination, a UTI, an ERTI, or medication change. So that vulnerability is increased. And so how it then is operationalized, frailty, they lose weight, people have low grip strength, they're feeling exhausted and fatigued, they have low physical activity, and they walk slowly. So this is the concept of the frailty syndrome. And sarcopenia, again, which Dr. Ward talked about, is a real concept we've all got to get our heads around, because it's happening to every one of us over the age of 40. We start losing muscle mass relatively early on, and it gets faster. We lose it faster after the age of 65. So all of us on the call tonight, we need to think about our own healthy aging, and Dr. Wardle will help us think about this. But we really need to improve muscle strength. This has a major effect on our future. So why recognise frailty? So I want you to think about this again from the perspective of being proactive. If an older person's relatively fit, well, let's prevent the onset of frailty. You know, we're all going to decline, but certainly if you actually try and change the trajectory of decline, then it's possible. A person with mild frailty, it can be reversed. You can put them back up on a higher level. A person who has moderate frailty, it can be stabilised and you can prevent deterioration. It's someone who's severely frail, well, certainly you'd be referring them to a geriatrician for a full assessment to actually look at all of the issues that need to be sorted out. It's complicated, but certainly even in that group, progress can be made. So the 2017 Asia Pacific Clinical Practice Guidelines showed the evidence that things can be done. So why even have a frailty screening tool? Okay, surely it's easy to recognise, you'll say. And of course, the pictures on the screen there go, well, pretty clear that on our frail scale, the people on the screen will be frail. That's pretty typical. What about this gentleman? He's 85. He's running a marathon in 4 hours and 15 minutes. So although he's, relatively thin, he's got grey hair, he's old, and so how is it that we pick the people in between? And that's where frailty screening tools are useful. But again, why worry? We worry about syndrome because of its consequences. Because think about our own days today. How many of our patients have presented, I'm feeling weak, doctor, I'm feeling tired, I've lost my appetite. And, if we're weighing them on a regular basis, which is a gold standard thing now, to weigh everyone aged 75 at every interaction. And I've actually found this has been incredibly helpful to monitor older people. They're the symptoms. The signs are going to be that they got thinner legs. And I was having a discussion with a man today. I said, what have you noticed about your legs? He said, yeah, they're shrinking. What are you doing about it? Well, why, doc? Why would I do anything about it? I said, well, what have you got to live for? Oh, my grandchildren, I want to get out to the bowls club. Well, if you lose more muscle, you're going to struggle to get out of that chair. So let's focus on your goals. So I actually timed his 5 sit-to-stands, and we were quite surprised together at how slow he was. So he's actually now interested because I've shown him some objective evidence that he's actually slower than he should be, and he wants to actually keep doing what he's doing. He also had some balance and gait abnormalities. Now, these are things that are signs of frailty. Severe deconditioning, as I said, is also another sign. But what happens? This is what happens. And basically, our hospitals are increasingly loaded. And as we're all aware, EDs, hospitals are full of older people now that have fallen. They've got injuries. They've got acute illnesses. Frailty increases the likelihood of being in hospital. Frailty increases the length of stay for any issue that a person presents with, and it has a big impact on recovery from surgery. So I'd like you all to think about this new care paradigm for older people. Now, I've borrowed this from geriatrician, Professor John Young. He comes from Nottingham in the UK, community geriatrician. And essentially, a lot of what happens today is, people are labelled as being the frail older person. They're often presenting late in our EDs or in our own surgeries. They've got to be fitted in because they've had a fall, they've got an abrasion, they've hit their head, they're not well, there's a delirium, or suddenly become immobile, or they're in EDs with these presentations and with ambulance picking people up left, right and centre. I was in the Clare Valley recently, and I did a talk for health professionals on frailty, and the ambulance officer said, you know what, the main people I pick up now every day are older people that can't get out of their chairs, that they are stuck or they've fallen over, and they have got to take them to hospital. Now that's crisis time. So they end up in hospital, it's episodic, it's disruptive to their lives, very disjointed. So again, is that what we want for our older relatives or our older patients? So let's think about what we do for all chronic conditions and think about frailty as a recognised long-term condition. Just think about it like diabetes. Okay, it's an older person living with frailty. With all chronic conditions, we take time to identify people with that condition because we can put in prevention, we can put in some proactive care, we can help educate people and their families about what's going on. We can support their self-management, and really importantly, we can plan their care. It can become very personalised based on their goals. And all this can happen in the community, in our practices that already have lots of older people, and we can actually try and reduce the amount of crisis that's occurring if we plan their care. And this is such a critical element, planning their care. having our health assessments, having our 3 to 6 month care plans done where we focus on planning their wellness. So what can be changed? We need to know a little bit about the evidence before we go gung-ho into this. And so the reversible areas are people's weakness, their slowness, and this low energy expenditure. So the anorexia of aging is what it's often called. As people slow down, they become less active, they're using less calories. So as they use less energy, they then it doesn't drive their interest in food. The more active we are, the more interested we are in food to eat. And so that then leads to undernutrition. And often people are simply having, I'll have a sandwich, I'll have some toast. And often we find they're having high sugar or high carbohydrate type meals and low protein, which then means that they're going to break their muscle down a bit more as they catabolize their own muscle to get more protein. Russell Cameron and Sue Curl, two geriatricians from New South Wales, had a really good study, and others have replicated it, that the interventions like where you improve exercise, improve the ability to actually have higher protein intake in diet, and having some support with loneliness can all reduce frailty and improves mobility. But the big thing that we need to be aware of, it only works if it matches the older person's goals. So it's one of those things, you don't just do stuff to older people. We need to work with them, find out their goals and link their goal to the intervention, because they're not going to be very interested in, oh, the doctor said I needed to, eat this extra protein and go and do all these exercises at the gym and build muscle. I don't want to do that. But if it's linked with a really important personal goal, then it will matter to that person and they're more likely to do it. So I want to introduce you to the concept of the 5 M's. So I've got the M&Ms up there. This comes from the Robert Hartford Foundation. They're a worldwide organisation that is interested in age-friendly health services. And when the research has been done from various consumer groups of older people, most health services are not age-friendly. So let's look at what the things are that older people are talking about in this context. They want to be asked what matters to them, because number one, they're interested in what matters to them. But often no one asks what matters. We're going to find, so what we do in our practice, we look at, okay, in our care plans, we make sure we list the patient's goals. It's the first thing in our care planning that occurs. What are your goals? What is getting in the way of you achieving your goals, like your personal goals? And what's your self-rated health out of 10? We get them to actually give them a 10, 0 to 10 rating, with 10 being fantastic and 0 being not great. And say, well, what is it that's stopping you being more than that? So really clearly defining what's getting in the way, because that then starts forming the basis of what is it I can do, and what is it my great team of nurses in our practice that are all being trained in this, what is it that they can do that can help that older person achieve their goal? Because it's about engagement. That these older people are very aware that their mobility, the second M, is actually critical to their life. Their mobility is linked with their independence. If their mobility changes, they are less likely to get out and meet friends, to do the things that they love, their hobbies, their interests, to go and see family. So mobility is key. They don't want to actually be asked, how many falls have you had, Mrs. Smith? But they are interested in how steady are you? What do you think about your mobility? Have you thought about anything that might improve your mobility? Because that's linked with their love of life. They're interested in how many medicines. Do I need to be on all these medicines, doc? They're interested in mentation, so the depression, dementia, and delirium. Dementia is something so many older people are worried about, but often not enough people are having their cognitive checks. Malnutrition, undernutrition in this group is huge, and it's all linked with people being frail. So it's a pretty powerful thing. And so going back to mobility, if we know that there is evidence to show that walking speed is the biggest predictor of a person that's aged 75 to 110, a much bigger predictor of their future than their blood pressure measurement, why is it that in the majority of practices, no one measures walking speed? You know, it's evidence-based practice now. It's a vital sign. The walking speed of an older person determines their future. And so taking more than 5 seconds to walk 4 meters basically predicts this future. So in the health assessments that I have in our practice and in practices that I support as a mentor and a coach, we actually put the walking speed, we teach nurses and doctors about the concept, put it into their health assessment, into their templates. So it's something they measure. It's very straightforward. You, in a practice with a corridor, you mark a 0 on the wall with a little bit of red and white tape, that emergency tape, 0, 1 meter, and then 5 meters. Now, the reason why we actually do the 0, 1 is we actually have a mobile start, because people with Parkinson's disease, people with arthritic limbs are often slow to get going. So we actually stopwatch it from the 1 meter to the 5 meter. It's 4 meters. It's a rolling start, and it's a much better way of actually being able to assess their walking. We then compare that year in, year out, and when people are slower than the 5 seconds, they take longer than 5 seconds, we then put in place a program of exercise to help them with their activity. But we've got to engage them, going back to what matters. And so what we use is this great little laminated slide. We say, well, to the older person, what do you think this is? And many people think it's a brain, but it's actually a CT scan of your thigh with the nice white, healthy femur in the middle, that lovely white area. We've got all that muscle and then a little bit of subcutaneous tissue and fat. So that's the 25-year-old, but look what happens when you're 75 and healthy. Your muscles shrink. And this has a big impact on people seeing, again, objective evidence of what's happening to them. We go, we want to really improve your muscle. And the only way we're going to do that is with an exercise program. And so that gets people's attention. But even more when we talk about that it's the muscles of independence, the ones that are going to get you up and off the toilet seat, out of your chair, off the floor if you happen to have a fall. And they often start taking notice about that because they may not have had this discussion before, but it engages them to think, well, what can I do, Doc, about this? And that's where we start having the next conversation. We go, because most people, again, when I look at the research that I've been involved with, working with older people, aged care organisations and practices around Australia, that older people are very reluctant to go to the gym. Older people are very reluctant to paying money to go to a whole raft of things that could maybe help them, but they are interested in actually doing something at home. And so one of the things that I find is actually teaching people. I've got these little exercises. I've got copies of them. I actually go through with them, an older person, and my nurses do the same thing, and say, these are some things that you can do at home. And I focus on one at a time. And the sit to stand is the favorite because it actually has the biggest impact on big muscles. And I just time people doing their 5 sit to stands when they're in my office and go, right, let's see how you go on the program, because once they're engaged, they want to do something. And one of the other secrets is they're doing it at home. They don't have to show anyone else, and they can achieve. And most people come back 8 weeks down the track having been able to achieve more than they ever thought. I simply put it to them, let's just try 5 sit-to-stands morning and night for the first week, 6 morning and night for the second, 7 morning and night for the next, and just a little bit like that. So I push them slowly. They love achieving and they do more. And by the end of the 8 weeks, they're up to their 20 twice a day. So that's something very simple that I get people engaged with by showing them their muscles. It also is evidence-based. We look at the Frailty Clinical Practice Guidelines mentioned. We've got to look at validated measurement tools to identify their frailty. Let's use physical activity with a resistance training. A sit to stand is resistance training. It's using a person's body weight to get up out of that chair. we really need to look at polypharmacy. We've got to address their fatigue. And with the fatigue, 50% of people, when we sort of ask them about, are they feeling tired, yes or no, oh yeah, doc, 50% will actually either be depressed or grief. Unrecognised grief is huge in this age group. Now, grief doesn't need an antidepressant. Grief needs a discussion, it needs some counselling, it needs some support, it needs people to recognise it. The other part, 50% of people that are fatigued, will have a medical issue that's either not being recognised or it's being undertreated, that needs some work. We need to address this weight loss. We need to increase their protein in their diet, and they may need some protein supplements and vitamin D as well. We also need to think about our care plans, and why this is important to talk about tonight is that, again, looking at your own care plans in your practices. The software that we have, the templates, gives us very shoddy looking care plans. You've got to say, are these plans that will help the wellness of an older person? We've got to make it matter to these people that are relying on us as health professionals to help make a difference with their lives. Now, those of you that have been involved with the Department of Veterans Affairs Coordinated Veterans Care may be familiar with their care plans. Now, their care plans are what I've based our practice care plans on, because they actually have a big component on goal setting and the person's goals. Because really, if we're planning care, planning wellness is the term that I put and that our nurses use. How can we plan wellness for an older person for the next 12 months? And we engage with them, we get their goals, and they see themselves in the plan. If you look on the left-hand side, need for prevention, goal, prevent attendance at the emergency, go to physio. Now, if you look at what's on the right-hand side, the person who gets the plan can see themselves in there. And we work on helping them see themselves in the plan, because that's what actually makes a difference. The evidence of motivation, the evidence of actually making it matter is critical here. So I want you to think about the Frail scale and think about using it. Now, there are many, and Dr. Ward will talk a little bit about others as well. But from a GP perspective, we've got to use things that are simple, time efficient, and that have been validated. Sure, it doesn't tell us about their cognition, but I would hope that in your 75 plus health assessments that you actually are using either GP cog or a mini mental, and as a minimum, getting the clock face done as a requirement, because it's so critical that in our health assessments we do a cognitive screen. A mental health screen, so the geriatric depression scale, have the Frail scale embedded in there as well. If you're not clear on how you should change your templates, talk to the PHN. They may be able to help you, or you may have a template whiz in your practice that can add the Frail scale in there. Some work I've done with Sydney North Primary Health Network has also helped, because what we want to do is try and make this as easy as possible. What should I do if there's a deficit in the FRAIL? And so on screen, you'll see, and if you like to take a screenshot, but it's on the Sydney North website, and I'm sure that the Hunter New England Central Coast PHN will put this on their website as well. But the deficits are there with the fatigue, resistance, ambulation, fibromyalgia illnesses, and loss of weight. What is it we can do? So the whole raft of options as far as what can be done in our practices, what potential referrals there are. And so that's a really good decision tool, which we're trying to make easy for primary care. So the summary and some take-home messages in the limited time we've had tonight. Hopefully I've got you thinking about recognising frailty as a long-term condition, rather than just responding, Mrs. Smith, you are just getting older, not much can be done. Let's look at using a screening tool at every interaction with older people. Now you're going to say, Chris, we just don't have time. We're under the pump as practices. But we are seeing this older people 17 to 19 times if you're 85, 15 times if you're 75. So we are seeing them regularly. Let's use the time wisely. Let's look at how we use our care plans. And I want you to think about care plans for diabetes for this group. Mrs. Smith, age 85, HbA1c is 6.7. Does she really need a care plan only focused on diabetes? She may have 6 other chronic conditions, but her biggest issue is her frailty, which hasn't been identified. Our care plan needs to include this. So let's look at having a specific care plan in practice. There's only for your 75 to 110-year-olds. That will make a difference to this group of people. And you could put your screening tool in there and make it really fly, because it's time efficient. Referral from multi-DT team care can make a difference. So if it's the exercise physiologist, the physio, but it only makes a difference if the older person sets the goals that they can see themselves getting to that simple achievement. Even if it's, as I said, let's improve how long it takes to get out of that chair. That's the first step. We've got to remember dignity in the care of older people is vital. What we do as health professionals, the way we communicate, the way we listen to people, but also the way that we communicate with other providers. I've seen so many letters of older referral letters that fail to mention a whole lot of critical pieces. We can't expect Mrs. Smith to remember everything about all her health conditions if she's got early onset Alzheimer's or has some cognitive impairment. So we need to think about vulnerable people need wraparound care. We need to take some responsibility for helping. Remember what was in the Royal Commission. The other thing, finally, before we finish, is you can't turn back the clock, but you can certainly wind it up, is a lovely saying. And this is what I work with older people, is that when they think back, oh, I used to be able to do that. Well, okay, I can't make you 50 again. I can't make you 30, but we can actually help improve. We can build muscle, give you some more energy. It's possible. And I want you to end on that really positive note before we go to Dr. Ward. So I'll look forward to taking questions at the end of the session.
Thank you very much, Chris, for that very enlightening presentation. It's clear from that the high quality care of the elderly is complex, time consuming, but incredibly important. And I particularly value the focus on proactive rather than reactive care there. Clearly, though, a lot of this work is going to require a major reorganization of the way a lot of our health systems work. So plenty of food for thought there. Thank you. I'd now like to pass over to Dr. Peter Ward, who is going to talk to us about frailty and sarcopenia. Thank you.
Thank you, James. I'll see if I can share my screen. So does that work, Phoebe?
Yes, perfect.
Right, thank you. So it's actually John Ward, but Peter sounds like a pretty good name to me. We'll take that. So what I want to talk about is just to talk about whether we should be talking about healthy aging or optimal aging. I have a few problems with the concept of healthy aging. Is frailty a useful syndrome? I want to talk a little bit about a life course approach to optimal aging, because I think that's the only one that makes sense to me. And then I want to talk about sarcopenia as a major public health issue, and then finish by talking about the primary care role in promoting optimal aging and the primary care role in frailty. So the reason that I have some concerns with healthy aging is that I think that's a privilege of people for whom genetics and epigenetics go together. Like that man we saw running, he obviously had good genes, and I presume his epigenetic factors were pretty good too. So we can't choose our parents, and a lot of us wind up with pretty lousy cardiovascular genes and genes for dementia and so on. Now, some of our epigenetic factors are within our control and some of them are outside our control. So we need to remember that probably something like about 20–25% of our population come from socioeconomic circumstances in early life that are very stressful, result in chronic stress, and don't set them up very well for later life and healthy aging. But of course, within our control, no matter what start we get in life, we do have control to a certain degree about things like exercise, diet, smoking, alcohol, and other drugs. So as a society, and this is partly why we formed the Hunter Aging Alliance, is to think about the idea of a life course approach to healthy aging. And if I was going to put if I was the government and I was going to put more money into healthy aging, I would put it into antenatal care, or sort of minimizing unwanted pregnancies, making sure that everybody got good antenatal and early childhood care, making sure everybody had secure housing. And as you know, at the moment, that's a really crisis situation, that there was an adequate income for everybody. I mean, people who are on New Start certainly cannot set themselves up for healthy aging. Good childhood and primary education, and of course, universal preventive health care and effective chronic disease management. And we know that in the Hunter now, there are very few bulk billing primary care practices, which is making it very difficult for a lot of people to access good health care. Talking about the frailty syndrome, and Chris, I thought the content and the wisdom of Chris's talk was just wonderful. He described the frailty syndrome of being a state of increased vulnerability associated with aging, a decline in reserve and function in multiple systems, and a reduced capacity to cope with stressors. However, my reservations about it is that I'm not convinced it's a useful syndrome to talk about in geriatric medicine. When I first started out as a doctor, there used to be a concept called acopia. So all these people who come into a hospital with multiple organ problems, so we didn't quite know why they were there, it was a combination of a whole lot of things, were described as acopia. Frailty, if used badly, is about as useless as that discussion. However, the concept as Chris describes it, I think would be very useful in general practice to work out who needs intervention, who needs referral on for comprehensive assessment, and good for some specialties, as I'll explain in a minute. Chris described all this, so I won't go through it again. This is the Fried scale, which is the sort of commonly one described. But the important point about the Fried scale is not what's in it, but what's left out. And there's so many things left out, like cognition, whether their chronic disease is well controlled, whether their pain is managed, their mood and anxiety, their sensory impairments, polypharmacy, alcohol, continence, autonomic dysfunction. And if I would add anything to the screening that Chris was talking about, it would be lying and standing blood pressure, which is certainly an important point when you think people are starting to deteriorate. But also on the other side of the positive factors, the things that are going for the person, like their social supports, their social engagement, whether they've got carers who are engaged with them, and their psychological strength. So there's sort of so much left out. So in geriatric medicine, and what I'd like to sort of encourage you to do when you approach older people, regardless of what organ system you're dealing with, what function you're dealing with, the things that you really know is, where is that person at now? What's the level of that function now? Cognition, their mobility, all the things Chris described. Where were they 6 or 9 months ago? And if there's a difference, if there's been a decline, we want to know the reason for that change. Now, if they're pretty much the same as they were 6 or 9 months ago, 18 months ago, you're not going to make a huge difference. So you know if it's chronic incontinence, if it's chronic immobility, all those sort of things, you're not going to make a huge difference. But if there has been a decline, then you really want to know why and what you can do about it. And having done all that, having determined that, then you've got to go on to your comprehensive assessment, which Chris described nicely, I think. Physical health, medications, cognition, mood, sleep, which is really important, mobility, balance, exercise, function at ADL, and their social situations, and the legal things that they need to do as they move into older age. Although I don't think it's a terribly useful thing in geriatric medicine, I think it is probably a good screening tool in general practice and identifies people for whom you want to do a comprehensive assessment yourself or refer on for a comprehensive assessment. It's probably a useful thing in hospitals too to think about because it's going to identify those people who are likely to develop delirium or post-operative complications, and probably those who shouldn't be going to ICU, who shouldn't be taking up valuable ICU beds. If it's in a pre-surgical anaesthetic assessment, then this identifies people who you want to intervene before surgery. So with preoperative exercises, have a look at their medication, adjust their nutrition, and perhaps think about delaying the operation until you've done some of those things. So I think it's very useful in those settings. One of the major components of frailty is undoubtedly sarcopenia. And I've been banging on about this for about 10 years. And when I started, people really didn't know much about this term. Nowadays, it's very unusual to talk to a group who really don't know about sarcopenia, which is really wonderful. By sarcopenia, we mean a loss of muscle strength or mass. As Chris said, it starts in the 4th or 5th decade. But the important thing is it increases markedly in chronic disease, immobility, and it's associated with obesity. I think it's a major cause of frailty and loss of independence. My sort of geriatric mantra is that you don't go to a nursing home because you're old. You don't go because you've got a chronic disease. You go because you're unfit, because you've allowed those muscles above your knee he talked about that get you out of a chair and out of the bed to waste away. And I always ask people if they know what the Latin name for those muscles are. And of course they don't. And then I tell them they're the nursing home muscles, because when they go, you go to a nursing home. So the confluence of aging, chronic disease and obesity, and we're seeing that now, this is what basically fills up primary care, is one of the major public health challenges of the 21st century, I think. How do we identify sarcopenia? It can be measured. There's ways of measuring it, but they're not clinically realistic. But if someone comes in and you watch them come in, they've got a waddling gait, and then, as Chris said, you ask them to get out of a chair without using their arms 5 times and they can't, then you know they're sarcopenic. And there are some simple bedside tests. If you get them to lie on a couch, flex their knees, and then you put your hand on their ankle and ask them to try and extend their knee against your biceps strength. Now, their quadriceps strength, no matter how old they are, should be able to overcome your biceps strength. So if they can't overcome that, you know they're sarcopenic. And you can get a simple tool that measures grip strength. Now, the risk factors of sarcopenia, firstly, age is probably one of the most important ones, but it's very easily reversible. With very simple ground-based exercises, you can increase muscle strength by about 10-15% in about 8 weeks. And when you think about that, you're losing at the age of, say, 70 or 80, about 1% of muscle strength a year normally, then you've given somebody back 10 or 15 years of life. If you weight load them, you can do much more than that. Any chronic disease has an inflammatory component, and all these inflammatory cytokines that are put out by chronic diseases are catabolic for muscle. And of course, people with chronic disease tend to exercise less, OA knees, and so on, COPD. Obesity is the interesting one. Now, we tend to think about fat tissue as inert tissue, and Chris showed you that CT scan of a 75-year-old's thigh, and the interesting thing was not just the lack of muscle, it was the huge amount of adipose tissue. Now, all of that adipose tissue is an active endocrine organ putting out about 13 different adipose cytokines, all but one of which are catabolic to muscle. So we see these big people and you think they've got big muscle. Well, they may have, but they're not good muscles. And then if you put somebody to bed, they can lose muscle at the rate of 2 to 3% a day. So someone who comes into hospital on Friday and is put to bed, and the physio comes to see them on Monday and they get them up, they could have lost 10%, 12% of their muscle strength. The consequences of sarcopenia, I think Chris mentioned a few of these. It reduces your physical activity, your capacity for ADLs, your quality of life, because everybody else is going out and doing things and you're too fatigued, tired. I think it's one of the biggest risk factors for falls and falls injuries. It's a lot of the reason people wind up going for joint surgery, particularly knee surgery. A lot of big people will wind up with dependent edema and risk of ulceration, cellulitis, and this can also often tip them into hospital, into nursing home. Their stay in hospital will be longer, and of course, the increased risk of nursing home placement. Talked a little bit about exercise, but perhaps some points that we haven't mentioned is that we can design an exercise program for anybody with any chronic disease. So no matter how disabled you are, even if you can't stand on your legs, we can do sitting exercise, you can do upper limb exercises. And exercise has so many other benefits for older people, apart from mobility and muscle strengthening. It's probably as effective for most of the depressions that we see in older age as pills. It's probably the significant and the most effective and strongest factor in preventing decline in cognition and in promoting cognition in people who've got mild cognitive impairment. And of course, it's a wonderful thing for socialization. People love exercising in groups and meeting people. It's good for the management of diabetes, hypertension, and osteoporosis if it's the right sort of exercise, and the capacity to manage in situations of stress. When we're talking about preventing falls injuries, we need to think about two things. One, preventing falling and preventing injury. So everybody falls. About a third of the people over 65 fall once a year. And most of us fall every now and then, but we don't injure ourselves. People in nursing homes will fall more often, but what we really want to do is stop people hurting themselves from falls. Now, there's a couple of components about that. One is the way people walk. Now, if they're fit people and they walk forwards, then if they trip or slip, they'll put their hand out, and the worst that'll happen is they'll break their wrist. No one goes to a nursing home with a broken wrist. But if they fall with this, if they walk in a sort of a sedentary way with their center of gravity backwards, they'll fall backwards or sideways, and they'll have a high risk of breaking their hip. And it's also about bone strength. And the important thing about bone strength is that bone density is only half the picture, but that's the one that doctors tend to concentrate on because they've got pills that can deal with it. Bone architecture is just as important as bone density, and any exercise, whether it's aerobic or resistance, will improve your bone architecture. With regard to nutrition, older people need about 20 grams of protein at each meal to prevent muscle loss and to benefit from the exercise that they're doing. Now, most people, older people and young people, probably eat very little protein for breakfast. If you can have an egg, that's wonderful, but most people tend to eat cereal or toast or something like that. And so the only way, if you're going to do that, to get protein for breakfast is to have a protein supplement. Very easy to do. Many older people will eat protein at one meal only because they'll have breakfast with no protein, have a big lunch, and then a very light snack at the end of the day. And of course, nursing home diets, again, may have protein at lunch only. So very important to think about the 20 grams of protein that you need at all meals to support your muscle. It's important that we protect people from iatrogenic frailty. And Chris mentioned the importance of deprescribing and how it's a high priority for him in his practice. I think that's just wonderful. And these are the ones that I concentrate. The very worst are probably opiates and the powerful analgesics. And interestingly, nowadays, they're much less used than they were 5 years ago. But it's the MS-Contins and the fentanyls and the pregabalins and those sort of things that you really don't want older people on. Long-acting night sedatives like Mogadon are terrible. I see an awful lot of people in their late 80s, 90s on high-dose statins, totally unnecessarily. Proton pump inhibitors, people tend to get put on them and left on them when they don't, when their reflux or heartburn's long gone. And of course, these drugs are powerful inhibitors of gastric acid and inhibit the absorption of a whole range of essential micronutrients that old people need. Long-term NSAIDs are really dangerous for older people. Multiple antihypertensives are another big problem because most older people don't take them. And then you send them to hospital. The diligent little junior medical officer writes the person up. They take them for the first time, get out of bed and fall over. So the way to approach hypertension, I think, is ambulatory blood pressure monitorings, which are much more useful than what we do, and the importance of measuring blood pressure lying and standing. Anticholinergics, think about those. They're in many different drugs, particularly things like antihistamines, psychotropics, and so on. You've got to be careful of those. And psychotropics are another big problem for older people. So de-prescribing, I think, is one of the really important strategies in preventing people from moving down that slope that Chris was talking about. So the summary of my views on sarcopenia are that the coalescence of older age, obesity and chronic disease is a major public health issue that we aren't really facing. Just have a look around your local shopping centre and see what's going to hit the health system in a few years' time, and see what the hospital's going to face and what the nursing homes are going to face. That's going to be a big problem. We should be promoting exercise and fitness in middle and older age, hopefully getting people into a habit before they enter older age, but it's never too late. I only took up heavy lifting about a year ago, so it's never too late to do it. I think exercise is the key strategy in the management of most chronic diseases in older age, but it's the one that the health system tends to entirely ignore. And exercise, sensible eating and reducing polypharmacy would minimise both sarcopenia and frailty. So what can primary care do for frail patients? Obviously, the comprehensive assessment and management plan that Chris was talking about, de-prescribe. Think about what can support these people at home, and that usually requires a referral to ACAT. Prescribe an exercise program, nutritional advice. Don't forget NOACs in atrial fibrillation, whether it's permanent or paroxysmal. They have the same risk of stroke. And very few people are too old to benefit from the use of NOACs. You've got to fall an awful long time to outweigh the benefit of NOACs in older age. And of course, don't forget vaccination, which I'm sure you don't. So this is what I spend a lot of my time doing now, the Hunter Aging Alliance. We formed this a few years ago because we largely had given up on the government for doing anything about older people. Join it. We'd love you to have you join it. Costs nothing to join, just say you support the thing. We work on a variety of strategies, and the two where we've probably had most wins lately are in the issue of developing a range of comprehensive exercise for older people and housing. We now employ someone to be working on a housing program of trying to develop up a system, provide housing for older women, and a infrastructure for investment in social and affordable housing. So if you're interested in any of those issues, then I'd love you to contact me. Thank you.
Thank you very much, John. And my apologies for getting your name wrong. My run sheet has you down as Peter, but clearly that's not correct. So thank you very much, John. A timely reminder there that aging starts basically from birth, and the focus on childhood and early life issues is very important. And I can also see those simple muscle tests along with the 4-meter walk that Chris was mentioning. They'd be very useful, I think, in clinical practice. I'd like to open up now to any questions that our audience may have for the presenters. So if you do have any questions, please put them in the chat. Just while we do that, I might start with one of my own to both John and Chris. Given the complexity of providing good care in this area and the inadequacy of our current approach, what hope do either of you have, if any, that the current Medicare reforms are going to address this and actually facilitate us moving forward to provide better care in the future in this area?
Well, John, I'm happy to have a crack first up. And I guess, look, I share your frustration, James. I've been lobbying politicians for the last 15 years or so on various elements of MBS reform, one of which has been that older people, they need more than 5 EPC-funded Medicare visits. And I've written to parliamentarians, I've made depositions. Not much has happened. If someone has a 75 health assessment, why wouldn't that qualify for them extra EPC items? But clearly that's falling on deaf ears because we have politicians that I don't think really have taken aging in Australia seriously. One of the things that I think about our current Medicare system is that you're right, it does simply reward volume rather than value care. And I think the care of older people in the way that John and I have been talking about tonight warrants us the slow medicine approach, which you may be familiar with, James, but I look at it this way. I want to enjoy my day at work. I want to feel as though I'm making a difference. And to do that, it means we put the thing down. It means, yes, I charge all my patients. There's a $20 gap for all my older people, but we give them time. And one of the things we do is that we don't charge them for their health assessments, their care plans. I've got a team of nurses working with me, and that we can get a lot more done. I don't need to be the person they spend all the time with. So when I look at how much time people spend in our practice, an hour with the nurse, they get sort of 15 to 20 minutes with me, and we do our regular reviews. If they come in between, there's a $20 gap. They're very happy to pay because they feel they get time and value. It's one of the really critical parts that our Medicare system has let slide, our own self-worth, us doing a really good job for the people that actually we are responsible for. So Medicare reforms, I'm not sure. I've been talking about it for a while. Not much has happened. So I think we've got to actually take some control ourselves and say, how do we deliver better care? We've got to set the practice up. We've got to say, this is what it costs to come and see us, have well-trained nurses in our practice, pay them well, and you make sure that we're utilising all of the current EPC items or care plans, health. Because if you look at it, the majority of people majority of practices do not bill the majority of items required to deliver good care.
I think it's a very complex area as well, and I think recent media reports probably don't help our argument saying that primary care needs better funding, because obviously there's a small faction that thinks we're just siphoning it all off without doing the work anyway, which I think has been shown actually to probably not be accurate in later articles. John, did you have any comments on that?
Well, I would think the answer to most of the chronic disease problems that older people suffer from may not be more doctors. It may be more specialist nurses, exercise physiologists, allied health people, psychologists, counsellors, referrals to gymnasium nutritionists, and I personally can't see it ever being met by fee-for-service medicine.
I think it's certainly a challenge, isn't it? I guess. Sorry, Chris, go on.
Yeah, I guess one of the other things, going back to just what John mentioned, because, when I actually, talk to my patients and say, look, what are your goals? And I want to live to 100, or I want to be able to, see my, granddaughter get married. And I say, so I actually challenge them. So I say, what are you doing about that? Because people just don't live to 100 by doing nothing. And actually, so we've got to challenge people in their thinking. And say, well, you've got to be involved in your own health. So one of the big things which primary care has talked about a lot in the past is that actually the self-management approach to chronic conditions, any chronic condition, which includes what we're talking about tonight, there's not enough emphasis and support on teaching people about chronic disease self-management. There's also not enough support for us as health professionals to recognise what chronic disease self-management means. Flinders University and Stanford in the US are the two world leaders in chronic disease self-management training for health professionals. And all of our primary care nurses, all of our GPs need that training, because that will actually make a difference. It actually helps empower people with a chronic condition to do a lot more themselves, rather than being reliant on the health system. Because as John's mentioned, investing in that means that, as a doctor, I can do a lot more high-level stuff, which is important, compared to a whole lot of lower-level stuff, which frankly may not be my best use of skills and time. But currently, we don't have enough education of our community about self-management. We don't have enough education of health professionals about the value of self-management.
Yeah, I think that's a very good point, and part of a wider issue about encouraging people to take responsibility for their own health and for their own health care at all ages. but yeah, clearly a difficult area. Thank you for that, Chris and John. We've had another question about social prescribing in this age group, and is there an agreed definition of what that means? Anybody care to take that?
Okay, so look, the way I see social prescribing is that okay, so this is something that I can actually interact with my patients, write down like going back to exercises or going back to joining a group, a hobby, in South Australia we have the Council of the Aging gym programs that actually it's called Strength for Life. So I actually that I see as social prescribing. Joining a community garden is social prescribing. So it's actually where people are getting out and interacting with life. And so our social prescribing can give them so many other benefits. Much like what John mentioned, the benefits of exercise is actually they socialise, good for their mental health, they're achieving something, they're learning something new, all of the essential areas of optimal or healthy aging. So that's my take on it. And I actually don't just simply go, James, I'd like you to go and join the gym. I will actually write it down and I will actually give them, use the SMART goal approach. Okay, these are the things that I'm suggesting that you do, and I'll link it with their goal.
No, but I'm listening to you, Ruby.
That would yeah, that would seem to be a very reasonable definition. John, did you have a comment on that?
No, I think that's a very good definition, except to say that I doubt that many GPs would know what's available in the community, and that's where you need other people to help you, whose job it is to learn what's available to refer people to, what exercise program, what groups, what educational programs, things like that.
And actually, if I could put my Health Pathways clinical editor hat on for a minute, that's exactly what Health Pathways does. So I'll just get a little plug in there. If you have access to a local Health Pathways
bloody computer
website, somebody's having IT difficulties, I think. The Health Pathways website can often point you towards community support groups and other sources of information in this area. So that's definitely worth checking out. Last call for questions. If anybody else in the audience wants to put anything in there.
James, I might, while you're just looking for questions, I might just share a little story which
Sure.
Goes on for something that John mentioned. I was running a community healthy aging workshop that was called Let's Chat About Healthy Aging up in the Clare Valley, and 50 people came along for dinner to the bowling club that evening, and they were interested in knowing a bit more. And so I had about an hour with them, and one of the discussions we had was about exercise, but also about eating protein. And I gave them all permission to have at least go back and eat their eggs and bacon, eggs and mushroom for breakfast. Now, it was really interesting, the reaction. It was a palpable murmur and a palpable look of delight and little fist pumps from people, because they go, my God, I've been told for so long it's bad for my cholesterol, that they've been simply eating, as they told me, all this, sheep food. And they were all going to make an absolute rush on the eggs of the local people up in the Clare Valley. So I think one of the things, coming back to what we can do, we can give people permission to actually eat food that's good for them. And not enough of that occurs. There are a lot of, social issues about cholesterol and eggs that just haven't been debunked enough.
Yeah, I think that's a very good point, isn't it? And particularly, as John was saying, the emphasis on making sure there's enough protein in the diet and it's linked to sarcopenia is very important. We've had another comment just raising the importance of acknowledgement of carers and the making sure that carers who are looking after people in this space have access to the appropriate supports, which of course is also an extremely important issue. So I don't think there are any other questions. So it remains for me to say thank you very much to John and Chris for your excellent presentations and for taking us through where we should be focusing in the future. And I will now pass things back to Phoebe to close. Thank you very much.
Thank you so so much. Thank you to James for chairing. You did an excellent job. Chris and John, an absolute pleasure. Fantastic presentations filled with fantastic information. Just up on my screen, I'm sharing just some health pathways information because we can't speak health pathways enough in our organisation.
Wow.
And I have posted, hopefully not spammed, but posted numerous times in the chat just the evaluation that if you could please complete, that would be fantastic. It's gathers important information for us about the content and how we provide education. So if you could please complete that, I'd be eternally grateful. Thank you to everyone for joining. I know that it takes time out of your family time, dinner time, depending if it's a bad day, potentially work time. I just see Jacqueline has put her hand up, so if she wanted to weigh in here, please do so.
Thanks, Phoebe. I just want to apologise for the very large text in the chat, but I just realised that Central Coast Health Pathways wasn't in the slide, so I just put the username and password and the link in the chat. I can't thank Chris and John enough. It was a fantastic presentation, and I'm sure we'll get lots of people accessing this from our education library. It was fantastic. Thank you.
Amazing. Well, thank you to everyone. Have a good night and look after each other.
Good night, Phoebe. Jack, thanks very much. Thanks, John and James. Bye.
Everybody.
Thank you.
Thank you.
Thank you.
That was a great presentation. Thank you.